guys, welcome back. The next topic we're studying is murmurs, and the first valvular lesion that I'll explain to you here is mitral stenosis. You are aware of the fact that the leading cause for this is rheumatic heart disease. Do take care of the fact that if they ask you what is the commonest valvular lesion in rheumatic heart disease in children, it's definitely going to be mitral regurgitation, but when it comes to adults, it's going to be mitral stenosis. Now let's look at how the disease will progress in this case. The normal size of the mitral valve orifice would be in the range of 4 to 6 square centimeter, though in this particular case I've shown a substantial narrowing to the tune of less than 1.5 square centimeter, which is for severe mitral stenosis. As a result of it, there is definitely going to be turbulence during the filling phase. You see, during rapid ventricular filling, when the blood will move from the right atria to the right ventricle, it's going to be a smooth passage because the orifice is normal size. But when it comes to the left side of the heart, since there is a narrowing of the mitral valve orifice, there's definitely going to be turbulence created during the phase of entry of blood from left atria to the left ventricle. The diagram here represents diastole, so you can definitely see that the turbulence slash murmur will be a diastolic murmur. This murmur will always be heard after the mitral valve will open, because you see, first mitral valve has to open, only then blood will go from atria to the ventricles. This explains the fact that in this condition, opening snap will occur, which will be relatively louder than normal. Why louder than normal? Because the pressure generated in left atria will be higher than normal because there's an obstruction present. Therefore, the left atria will generate more force than normal, which explains the loud opening snap. And it will be subsequent to the loud opening snap that you will be able to hear the noise, or you will be able to appreciate the murmur. And to appreciate this better, you can also turn the patient to the left lateral decubitus position. The logic is that the heart will come closer to the chest wall, and therefore you will be able to rather hear the murmur relatively better. Now let me just time this before you. This is what I said. The period between S1 and S2 would be systole, and period between S2 and S1 is diastole, and I've deliberately drawn them asymmetrical because the duration of diastole is always more than the duration of systole. Now, when it comes to S2 in this condition, what I want to highlight is that the intensity of A2 and P2 will remain normal. But as you progress into the diastole, the moment the opening snap will occur, you will hear a loud opening snap. This is primarily because of the higher pressure generated, and then this murmur will start. It will peak bang in the middle of diastole. Then the intensity of the murmur will definitely start falling, though you will be having a small secondary spike as well, which I've highlighted in the form of a star. Please appreciate that this terminal part that I'm highlighting of diastole is called as atrial systole. You can see a small spike which is occurring right before the murmur dies down in the phase of atrial systole, because once the heart has filled blood into the ventricles, then atria will also contract. Maximum filling of blood in the ventricles occurs during the phase of rapid ventricular filling, but subsequent to that, even atrial systole contributes 30% of the filling. My point is, the moment the atrial systole will occur, even that will be working against this physical obstruction. So even then, there will be a slight increase in the intensity of the murmur, and this is called as pre-systolic. Why pre-systolic? Because after S1, it is the ventricular systole that will start. It is happening during atrial systole, but my point is, after S1, ventricular systole will start. So the word is pre-systolic accentuation, and I'll just jot down the data before you. This is one of the crux of this particular discussion. I mean, they love to ask about what I'm teaching you right now. The murmur of mitral stenosis is going to be a MDM, that is a mid-diastolic murmur, and then it has a small secondary spike. This small secondary spike may not be appreciated also. I'll also explain to you when would you not be able to appreciate it, but at the moment the name for this would be technically called as PSA, that is pre-systolic accentuation. Now, since I explained to you that this pre-systolic accentuation is due to atrial systole, it can also disappear. Why? Because lots of time in patients of mitral stenosis, the left atria is working more than normal, so there can be arrhythmia developing in these patients. The arrhythmia that will develop is atrial fibrillation. Once atrial fibrillation will develop, then there will be twitching of the atria. There will not be a sustained contraction. There would be a twitching, and twitching cannot generate the force. And if there will be no force generation, then pre-systolic accentuation will disappear. I want to highlight that in one of the exams, this was actually combined medical services exam, they had asked in which situation in mitral stenosis patient will the pre-systolic accentuation be absent. The logic is pre-systolic accentuation will disappear if atrial systole will not be happening. When I say atrial systole is not happening, then what is happening? Atria twitching. And what is the twitching called as? The twitching is called as atrial fibrillation. In fact, I've explained that atrial fibrillation is overall the most common sustained arrhythmia. whether it be hypertension patient, whether it's going to be a patient who's geriatric age group, whether it is mitral stenosis patients, it is atrial fibrillation which is the troublemaker. And God forbid, if this atrial fibrillation persists, they can even be clot formation in the left atria, and these clots can go into systemic circulation, causing development of embolic stroke as well. The main treatment that I would like to give to a person of severe mitral stenosis where the orifice size is less than 1.5 square centimeter, it is not 1, guys, it is given as less than 1.5 square centimeter, we would like to go in for a balloon dilatation, but my patient did not get the procedure done. And like it's so common in India, patients will keep on delaying, and as a result of it, because this lesion is progressive, so I have now highlighted that the disease has resulted in further narrowing. In green color, I am now highlighting that this opening has become even more smaller. If this opening will become even more smaller, then the pressure generated will even further increase. I'm just highlighting in green to highlight, because the disease is progressive, left atria will generate more force. If left atria will generate more, the more force will result in earlier opening of the mitral valve. I repeat the fact once again, because pressure is increasing, guys, the increased pressure will cause an early opening of the mitral valve, and because of this early opening of the mitral valve, I'm shifting the position of the opening snap a little towards S2 to highlight that this will be the new position of the opening snap. It will definitely be louder than what it was earlier, but at the same time is also occurring earlier. The word earlier is coming, why? Because the pressure is relatively higher. Therefore, see what happens. There's going to be a dramatic increase in the length of the murmur as well. You can see that I've shown a green and a blue line, but there's a definitive or a marked increase in the duration of the murmur per se. Well, the logic is very simple, guys. What I'm trying to explain to you here from the exam perspective is that the examiner wants to see, are you aware of what is going to decide the severity of the disease? If he says what is the main determinant of the severity of mitral stenosis, do not answer it as loud S1. Do not answer this as loud P2. That's the common errors that most people do. I agree, loud P2 is suggestive of pulmonary artery hypertension, but do not answer it as loud S1 or do not answer it as loud P2. Do not even answer as the intensity of the murmur. Mark my words there. It is not the loudness of the murmur, it is the length of the murmur. The logic is, guys, if the opening will become small, the blood is going to take more time to go across this area. I repeat the fact once again. If the opening will become smaller, the blood will take more time to go across this area. If the blood will take more time, the duration of the murmur will increase. So severity of mitral stenosis is directly related to the length of the murmur / duration of the murmur. That's the one of the important key points that I want you to remember after the name of this longest murmur. MDM with the PSA. PSA is absent in atrial fibrillation. Right now, I have just emphasized before you why is it written in the textbook that the main determinant of severity of mitral stenosis is the duration of the murmur / length of the murmur. Now, because lots of time people are able to crack this by simple logic. No, if opening is small, time taken will be more. So the examiner is obviously, in a fix how to trouble you. So let us now see how the examiner will try to trouble you with this information. Please focus on the position of the opening snap. Compare the gap between the second heart sound and the opening snap, which was earlier present. And now look at the gap between the S2 and the opening snap. You will definitely notice that the gap has dramatically reduced. And in fact, I've just highlighted this in a dotted red to highlight that this gap has become lesser. So let me just write the data once again. What I was saying was that severity is directly related or directly proportional. A bit of mathematics here, right? This severity is directly proportional to the length of the murmur. In some multiple choice MCQs, he might slightly change the data. He might say severity is inversely related. Again, mathematics coming up here, guys. If the disease will become more severe, then this gap is becoming between S2 and opening snap is becoming lesser. So he will write S2 opening snap gap. If you got this, you will get questions of mitral stenosis, especially the severity component, right? The bottom line is, guys, there are three aspects I want you to remember. The murmur of mitral stenosis is mid-diastolic. That you already know. It has a pre-systolic accentuation. You already knew. Point number one, when does it disappear? Atrial fibrillation. What is the main determinant of severity? It's going to be length of the murmur. And in some questions, just to make it a little, mathematically oriented for you, it is severity is inversely related to S2 opening snap gap. Both basically mean the same only. It is just that it's to satisfy the I would say the ego of the examiner that they love to ask about it, and we'll be ready with that kind of an information. And as the disease will progress, obviously the back pressure changes will start occurring in the patient, because higher is the pressure of the left atria, this pressure is going to be transmitted to the pulmonary circulation, so pulmonary edema will come in. Once the pulmonary edema comes in, there would be definitive hypoxia. So even later, pulmonary artery hypertension would come in, and because of this, even right ventricular enlargement can occur. Guys, mitral stenosis is a disease which definitely contributes not only to pulmonary edema, just like any cardiac cause, but it can actually cause right ventricular hypertrophy. The surprising thing that I've taught you is that in a patient who's suffering from mitral stenosis per se, the problem is in the left side of the heart, but enlargement of which ventricle is occurring? Right ventricle. It is a right ventricular hypertrophy. I'll draw a line diagram once again to highlight that before you, but the logic I want to highlight once again, guys, is the problem is in the left side of the heart, but the chamber that hypertrophies, the left atria will dilate. Left atria will not hypertrophy. Hypertrophy occurs in mitral stenosis of the right ventricle, and that is why it is usually asked in the questions. And what I'm discussing before you are usually going to be the questions related to mitral stenosis, where he will either say that select the correct options for it, or he'll say which of these is the wrong statement. So therefore you need to be careful with every one of the statements that I'm mentioning for the most common valvular lesion that is seen per se with rheumatic heart disease. I have already explained to you that in pediatrics it's gonna be MR, and lots of time in your wards when you have patients admitted, it could be a combo of mitral stenosis and mitral regurgitation. I shall now be explaining to you why these patients would be coming over. You see, primarily because of this inflow obstruction into the left ventricle, therefore there's an increased pressure developing in the left atria, and the same pressure is also transmitted to the pulmonary venous circuit as well. This translates into pulmonary edema, as I explained. So most complaints initially will be that of breathlessness, initially on physical exercise, and then subsequently even at rest as the disease will worsen. Now the bad news is that pulmonary edema will contribute to hypoxia, and the next component I want you to listen with a lot of care. You see, hypoxia is a trigger which can actually contribute to vasodilation of most of the blood vessels in the brain except one, pulmonary artery. The pulmonary artery does not dilate in response to hypoxia. You see, pulmonary artery is the only artery which is named as an artery per se, but is actually carrying deoxygenated blood. It behaves different from other arteries, so there is a vasoconstriction of the pulmonary bed per se, and therefore the pressure in the pulmonary artery will start rising, and there would be a pulmonary artery hypertension. I repeat the fact, I said long-standing pulmonary edema will contribute to hypoxia, vasoconstriction of the pulmonary bed, and PAH will occur. Because of this PAH now, it is the right ventricle of the patient that will have to do more work than normal, and when the right ventricle will have to exercise more than normal, then there would be a right ventricular hypertrophy in the patient as well. Most of the time, the age group of the patient will be given to be beyond 18 years of age, and this patient will come to you with complaints of dyspnea on exertion and orthopnea. In fact, most of these patients will develop a habit of sleeping with pillows behind their back, because the moment they lie supine, obviously the pulmonary edema component will deteriorate. They will also blame the night time for disturbed sleep. I mean, person is not a technical one, so he's not understanding that it is not that he's having a disturbed sleep at night. I mean, the sleep is always going to be disturbed whether at day or whether at night, because the moment he will lie down flat, the breathlessness component will worsen. This person will say that I could not sleep last night, and therefore I feel very drowsy and dizzy, and at the same time the breathlessness also comes at night. You see, in asthma also bronchospasm is worse at night. Here it is breathlessness again coming at night, not because of the bronchospasm component. In this guy, the main reason for breathlessness coming at night would be the supine position of the body. So as I highlighted, a lot of them will develop a habit of actually sitting in a reclining position and then going off to sleep. The bad news is there would be a dilatation of the left atria. There's a structural damage to the left atria. It gets relatively dilated. So one bad news can be that it can press on the recurrent laryngeal nerve. That can contribute to hoarseness of voice, and that explains why you read about Alterner syndrome in literature of mitral stenosis. I repeat the fact once again, the chamber that is becoming hypertrophied is the right ventricle, and the chamber that is dilating is the left atria. So this results in Alterner syndrome manifestations, and well, this is not over. The bad news is that the left atria will dilate even much more than what it was originally, and this can set off an arrhythmia by the name of atrial fibrillation. I've already told you atrial fibrillation happens to be the commonest sustained arrhythmias all across in cardiology, and now because the atria are twitching, therefore clots can be formed. Because of these clots, which would be numerous in left atria and left atrial appendage, if any one of these clots will go into systemic circulation, they can definitely go into the brain and can contribute to development of embolic stroke. In fact, recently one of my students had sent me a message across. He told me that a patient of mitral stenosis who's admitted in the ward of his, actually when he went for the rounds next morning, he found that he was having hemiplegia. Well, the reason is pretty obvious. This patient was not put on anticoagulation, though he was documented to be of mitral stenosis. Maybe the echo may not have been done on time, and therefore the clots which are already pre-existent went to the brain and resulted in neurological deficits developing in this patient. Subsequently, as the disease will evolve even further, another possibility can be that because of this pulmonary artery hypertension, the exercise intolerance of the patient will deteriorate even further. I want to highlight, already he was having problem with respect to climbing of stairs. But when you find that the same person has suddenly deteriorated over the previous, let me say 1 or 2 months, then this sudden deterioration over and above what was already pre-existent could be due to the pulmonary artery hypertension. That is why doing a serial echocardiography in these patients is all the way important, and we will also study about drugs which are useful for management of pulmonary artery hypertension. Once the person will start having PAH, then right ventricle is affected. So there is no big deal that he might actually mention one of the features of right ventricular decompensation, that would be ankle edema developing in the patient in the long run. The bottom line is, in individual mitral stenosis, the problem is on the left, but the manifestations of the right side, non-compliance or poor compliance, will also start coming into being. Now I'm going to be examining this patient, and the first thing that I would definitely notice will be a very characteristic tapping apex beat. Well, this guy is going to have a low cardiac output, no, because after all, less blood is going to come in the left ventricle of the patient. So to reflect this low cardiac output per se, they use the word tapping apex beat, and then we will focus on the first heart sound and the second heart sound. In this condition, you will always be having a loud S1, as I've highlighted even in the earlier lectures where I have spoken about heart sounds per se. I would like to repeat the fact, the reason why it is a loud S1 in the patient is because there will be increased pressure in the left atria. Increased pressure in the left atria will obviously contribute to a forcible opening of the mitral valve. Agreed, opening snap will definitely be loud. The point of mine is that when these valves will open with more force, they will also snap back with more force also. So the technical reason why you get a loud S1 is enhanced transvalvular gradient. You see, the bottom line is there is going to be elastic recoil because the valves are going to be forced open with more force than normal. Therefore, they'll snap back also with more force, and there's a loud S1. But then don't be surprised that he might write the word soft S1. Why soft S1? Because in the later part of the disease, there would be calcification of the valve. If calcification will occur in the valve per se, then what is going to happen to elastic recoil? The recoil is going to become lesser. So soft S1 in mitral stenosis basically indicates calcification mitral stenosis. That's an important pointer that I want you to remember. In fact, in some questions, he might actually not talk about the intensity, but talk about the splitting component. You see, first mitral valve closes and then tricuspid valve closes. And what is happening in this guy is that the orifice is progressively becoming narrower. So the blood will definitely take more time to go across this area. So not only you will be having an increase in the duration of the murmur, but as a side that because it will take more time for the blood to go across the mitral valve per se, the mitral valve will close late. If mitral valve will close late, I will shift this line slightly towards the right to say that as the disease will progress, mitral valve closure will keep on getting prolonged. I repeat the fact once again. If the opening is narrow, then the valve will have to remain open for relatively longer time, which basically means it will close later. And therefore, if the gap is reduced, you could also read about a narrow split. First heart sound. When I have described aortic stenosis, I have talked about narrow split second heart sound. But today I'm teaching you narrow split first heart sound is a feature of mitral stenosis. If he still does not take treatment, there's a possibility that mitral valve and tricuspid valve will close at the same time. That means it's gonna be single S1. And if he still does not take treatment, there could even be overshooting, no? Then you will be having a T1 M1, that is reverse splitting of the first heart sound in the patient. So there are after all 6 inputs that I have told you for first heart sound in a mitral stenosis patient. It can be loud, it can be soft, it can be narrow, it can be single, and it can even be reverse split first heart sound, and any of these or many of these can definitely be asked. Let's now talk about what's going to happen in the second heart sound of these patients. So per se, when it comes to the intensity of A2 and P2, it will remain normal in majority of cases. But if, as I said, if it's a neglected case and if pulmonary artery hypertension will occur, then he will definitely mention regarding loud P2. Why? Because the pulmonary artery pressure is more, so it will force the valve from behind. You see, pulmonic valve is closing and somebody is pushing it from behind, so it will snap, or it will close with more force, and that is why you get a loud S2 present in this patient. The next point is an MCQ statement, third heart sound. You see, third heart sound is seen in ventricular failure. But in this case, as I proved to you, there is no failure. There is a right ventricular hypertrophy developing in the patient. Obviously, the compliance of right ventricle will be affected, but the point is it is not getting failed. It is rather getting hypertrophied because it has to work against the resistance of pulmonary artery hypertension. A third heart sound per se, guys, is always seen where the ventricles are dilated and there's a turbulence present. In this particular case, since there's a hypertrophy, third heart sound would not be present. So that is itself a question that which of the following is correct about mitral stenosis. He might jumble up the data. The correct statement is third heart sound is never gonna be present. When it comes to murmur, I've already explained in the previous slide, it is going to be a mid-diastolic murmur with a small secondary spike, which we are going to call as a pre-systolic accentuation, and the pre-systolic accentuation can even disappear in case there's a atrial fibrillation developing in the patient. The intensity of the murmur will increase if you are going to be having a progression of the lesion. The length of the murmur, the duration of murmur will increase, and it is better heard. If he says, I mean, in which position, obviously you are auscultating the patient, but if you turn the patient slightly to the left side, then the heart will come closer to the chest wall, and in left lateral decubitus position, you will notice that the intensity of the murmur will be heard relatively better. It's not that I'm saying the murmur will become grossly loud, but it is just that you will be able to appreciate it better. One of the important reasons why this topic is being discussed at this juncture is to mainly sensitize you to the fact valvular lesion that can cause stroke. Mitral stenosis is one of those. Mitral stenosis is one valvular lesion that, even if it's occurring even at a young age, it can contribute to development of embolic stroke per se. And I want to remind you that in neurology, when you read about the etiology of the most common variety of stroke, that is ischemic stroke, it's going to be cardioembolic. And when he talks about cardioembolic, then he's going to say a very important statement. So listen to my next statement with a lot of care, guys. One of the leading causes of embolic stroke is non-rheumatic atrial fibrillation. I am teaching you at the moment rheumatic atrial fibrillation because the incidence of rheumatic heart disease is relatively lesser due to advent of antibiotics, better care at the moment. So I want to tell you that the number one cause for embolic stroke is not rheumatic, it is non-rheumatic atrial fibrillation. Why does non-rheumatic atrial fibrillation occur? That occurs in dilated cardiomyopathy. Usually it's alcoholic. He will have dilated cardiomyopathy, structural damage, and structural damage to the left atria can trigger again a arrhythmia. I want to highlight this fact, guys. If he says what is the leading cause of embolic stroke, it is the word non-rheumatic atrial fibrillation. The current topic is obviously rheumatic atrial fibrillation. The incidence of this has become relatively lesser. Coming to the workup of these patients, I will be doing a ECG and a chest X-ray, but the main way to diagnose this condition and confirm the diagnosis would be a transthoracic echocardiography. Usually in the ECG, they love to ask about two aspects. One would be an increase in the duration of the P wave, and second is increase especially in the height of the P wave. You see, I've already explained to you that the normal duration of the P wave will be approximately less than 120 milliseconds. One small square is 40 milliseconds, so that means that in a normal person, the duration of the P wave would be in the range of about 3 small squares. But what I've done here is that I have tried to increase the duration of the P wave. I've also tried to incorporate a small notch in the top of the P wave, and more importantly, because current will take more time to go across the enlarged left atria. The logic is because the current will take more time to go across the enlarged left atria. Therefore, the ECG finding very characteristically asked for this topic would be P mitral. In the same patient in the long run, you will not only be having an increase in duration, but even a height of the P wave will be increasing, that is P pulmonale. In fact, the definition of the P pulmonale will be the vertical height would be more than 2.5 millimeter in the limb leads. I have also discussed regarding pseudo P pulmonale. This is optional, though this is discussed subsequently in ECG findings seen with hyperkalemia and hypokalemia. But since I got an opportunity, I am just making you note it down here. That is optional because it's obviously covered subsequently. Pseudo P pulmonale is a feature seen with hypokalemia. P pulmonale signifies pulmonary artery hypertension developing in the patient in the long run. Initially, it is a left atrial enlargement, and then the back pressure changes will contribute to right-sided enlargement in the patient as well. In mitral, it is mainly the duration that is affected, whereas in pulmonale, it is the vertical height of the P wave that will be affected. So, if I just represent a normal P wave, a P pulmonale will definitely be having a higher amplitude. We will now focus on the radiological findings that can be encountered, and very classical ones are seen. So, let me just explain them to you. Let us say this is the representation of the right cardiac border, and this is going to be the left cardiac border, and let me put up the names here. The right cardiac border will be formed by the right atria, a small part of SVC and IVC, but right ventricle does not form the right heart border. You know that from anatomy as well. Right ventricle is inferiorly located. So one of the statements of mine, though I'm not writing at the moment, is right ventricle forms the inferior surface of the heart, the one towards the diaphragm. Right ventricle per se does not form the right heart border in an X-ray. Now this convexity that I've highlighted before you in the chest X-ray is called as aortic knuckle, and right below this is present a small concavity for pulmonary artery. The next structure below this is left atrial appendage. Mark my words there. It is not the left atria, it is left atrial appendage, and then is obviously the left ventricle. Now, what I want you to understand, especially for this condition, is that in the long run, as the disease will progress, there can be a fullness in the pulmonary artery area. I had earlier, I'll just zoom it in slightly. I had earlier shown in blue a concavity present in this area, but now I'm going to highlight a convexity. This convexity is primarily, or the fullness is going to occur mainly because of the pulmonary artery hypertension that will come in this place. Similarly, in the same patient in the long run, even there could be dilatation of the left atrial appendage also. So I've shown a little bit of more convexity with respect to where the left atrial appendage is present. And now what I'm going to do is that I'm going to draw a straight line which is going to cut through all of this. What I'm trying to teach you is what is taught always in radiology, the word straightening of the left heart border. I've tried to sensitize you to the fact that why is it written straightening of the left heart border is a feature of mitral stenosis, because you are having a fullness present in one, the pulmonary artery area, and second is the fullness with respect to the left atrial appendage. Please remember the fact that left atria per se does not form the left heart border. It is left atrial appendage that is forming, but yes, left atria will also enlarge. The left atria will rather enlarge eccentrically. So when the left atria will enlarge eccentrically, you can very well see that it will also start pushing the right atria. And the moment it will push the right atria, you can get another radiological finding in the patient, that is double atrial shadow. Let me just jot them down before you. One of the highlights that you will find always with radiologist highlighting the statement that I have just explained to you, why is it occurring, is because you see the aortic knuckle prominence will be less convex than normal. Why aortic knuckle will be less convex? Because less blood is going in the aorta. So the aortic knuckle convexity is lesser, but pulmonary artery area was concave. That area has become convex. Left atrial appendage area has also become convex. So the point is straightening of left heart border. I'll repeat the facts once again, guys. I said the aortic knuckle convexity will become lesser because less blood is going, and there's a fullness in the pulmonary artery segment and left atrial appendage. That explains straightening of the left heart border developing in these patients. The second feature is double atrial shadow. This has also been asked in the exam, both in, you can call it radiology/medicine. The question said, what is the reason for double atrial contour/double atrial shadow? The answer is enlarged left atria, which is pushing the right, which is contributing to this manifestation. Over and above this, obviously findings of pulmonary edema would come in. They would be probably in a Batwing configuration. So standard pulmonary edema findings are already discussed in congestive heart failure and at multiple places. So I mainly wanted to focus on what will be the impact on the heart borders per se with respect to mitral stenosis. One more feature that I can say, though in exam it will not be helpful for you, is with respect to the tracheal bifurcation. You see, this is what is shown here as the carinal angle. The normal carinal angle will be about 60 to 70 degrees, and your and my left atria is right here sandwiched between the tracheal bifurcation, or the carinal angle per se is because of the fact that the trachea is bifurcating and below that is the left atria. My point here is that when the left atria will become bigger, then this angle will definitely increase. The normal cranial angle is 60 to 70 degrees. Now in the exam, obviously you will not have any geometrical instruments by which you can measure it. So as I said, it will not have too much of applied aspect present. But yeah, from the radiological perspective, if you find widening of the cranial angle written, that is one more feature. I repeat that again, widening of the cranial angle is one more feature suggestive of left atrial enlargement. And another one that I showed and is relatively easily visible is double atrial contour. Now we will focus on the echocardiography report of this person, because the investigational choice for mitral stenosis is transthoracic echocardiography. Here there are two findings that they love to ask. One is the standard candle flame jet. Well, the term is mainly to highlight, you see, candle flame, because there would be a tapering occurring. That's why the candle flame jet. And alternative terminology that may be written sometimes is because of the displacement of the valves also, that is called as hockey stick sign. So because of the classical terminologies, I definitely would like you to remember. And in fact, hockey stick sign is taught in other allied subjects as well. So I would just like to, or subtopics per se. So I would just like to highlight about the fact that a radiologist or a neurologist will talk about hockey stick sign on an MRI head also. In the later part of the disease or later part of the lectures, I've talked about variant Creutzfeldt-Jakob disease, VCGD, which is also gonna be transmitted by intake of beef. In fact, I've discussed it even in the epilepsy section, variant Creutzfeldt-Jakob disease, because it produces very characteristic EEG findings. But at the moment, I want you to remember the MRI head findings of variant Creutzfeldt-Jakob disease, that is called as hockey stick sign. In contrast, sometimes you will also read about hockey stick sign on ECG. Mark my words there, guys. I said hockey stick sign on echo is in mitral stenosis, but hockey stick sign on ECG can be seen with digoxin, because digoxin causes a very classical ST segment depression, and digoxin administration can contribute to this. If he talks about echo, then obviously the standard answer is what we're discussing at the moment, mitral stenosis. So that was just a allied aspect that I want you to remember. Let us now talk about what are we going to do for the management of this patient. If he specifies the word severe mitral stenosis, because if it's going to be mild to moderate, I can manage medically also. But when it's going to be the severe variety, then the treatment of choice for this patient would be to go in for a balloon valvotomy. Will dilate the narrowed valve with the symptoms of the patient will definitely reduce. The excess that I will take will be from the basilic vein of the patient, from the cubital fossa. From the basilic vein, I'm going to navigate up towards the heart, towards the superior vena cava. Then I'm going to via the subclavian vein, obviously. Then I'm going to reach the right atria. Then I'm going to puncture, the word is puncture, the interatrial septum and reach into the left side of the heart. The device that is going inside, that is obviously not blind. Under fluoroscopic monitoring, we can actually see the device going inside. And at the same time, you will also have a pressure sensor that will tell you that you are in which chamber of the heart. Now, as you navigate from the left atria towards the left ventricle, that is where the pressure gradient in the sensor will begin to increase, because wherever the narrowed valve is present, at that area, the pressure gradient will definitely rise. Once you are at the right spot under fluoroscopic guidance and the pressure values, you will now be deploying a balloon here. This balloon will definitely dilate the narrowed valve and ease off the symptoms in the patient. So the message is percutaneous mitral balloon valvotomy or PMBV is the best treatment that you can offer to a patient of severe mitral stenosis. Obviously, lots of time in government hospital, either this facility may not be available, or even if available, the cases might be booked and the date of the patient in government hospital might come after 6 months or after 1 year. So there is a distinct possibility that either the patient did not get the procedure done, or the hospital was having so much of case backlog that they did not give a proper date to the patient. So let us now see what is going to happen if a person is not treated on time. A severe mitral stenosis patient does not have the financial muscle to get it treated from a corporate private hospital, which would be charging maybe 2 lakhs for the procedure. If the procedure is not done on time, then after a couple of months to years, there would definitely be calcification developing in the valve, and there could be a calcified mitral stenosis developing in the patient. Do remember, we are talking about a severe variety of mitral stenosis where calcification has occurred. In this situation, if I do a percutaneous mitral balloon valvotomy, listen to this carefully, the moment you will do a balloon dilatation in a calcified valve, the valve will break like a biscuit. The valve will crumble like a cookie and the calcified fragments will go towards the brain and will cause embolic stroke in a patient. I want to highlight this, guys, that percutaneous mitral balloon valvotomy is absolutely contraindicated in a patient who's having a calcified mitral valve. Why? I explained that the moment the balloon is deployed, the force of the balloon is gonna fracture the valve and the calcified fragments will go into the brain of the patient. So he will deliberately ask you, when is PMBV contraindicated? One of the standard reasons is calcified severe mitral stenosis. Let's do this again. This will also help me know whether you understood my this point or not. Let us assume you are having a patient in a hospital who's having a combo lesion. He's having severe mitral stenosis with mitral regurgitation and you're planning a balloon dilatation. If you do a balloon dilatation in a severe mitral stenosis, obviously it will help the person, but the bad news is that it will worsen the mitral regurgitation component. You see, the coaptation of leaflets has to be perfect. If you dilate this defective valve, then the problem is the mitral regurgitation part will worsen. So this is for the second time that I'm teaching you percutaneous mitral balloon valvotomy is contraindicated in a combo lesion of severe MS with MR. Let's do it one more time so that this becomes a permanent memory for you. Let us assume you have a person of severe mitral stenosis and the echocardiography is already showing left atrial appendage clots. Now, because the left atrial appendage clots are present, obviously they are a threat to life. They can cause stroke. So the first step in management of this person will definitely be anticoagulation. I cannot take a chance with clots in place because already the hole is small. So at least the clots will have lesser chances of going into systemic circulation. If I dilate this opening, the clots in the left atria will have higher chances of going into systemic circulation and will cause embolic stroke. So in a person in whom you have documented the clots anyway, you need to put the person on aggressive anticoagulation to prevent embolic stroke from happening, and the procedure cannot occur at this particular junction. Three scenarios where I have highlighted when would you be not going in for percutaneous mitral balloon valvotomies right before you guys. The 3 points are, I would like to highlight once again, a person with severe mitral stenosis which is calcified already, or a combo lesion of severe MS with MR, or there is in situ left atrial appendage clots. In both the scenarios, it really does not make sense for a doctor to actually try and do a balloon dilatation. For mild to moderate cases, obviously you can be going in for conservative management, like you can be using drugs like digoxin, and for the edema component, if it is occurring, you could be using spironolactone. I agree that if pulmonary edema is severe, you might even use furosemide. As it eases off, you will use thiazide. But the big problem with furosemide and thiazide is the hypokalemia component. So in mild to moderate cases, you can definitely medically manage the patient with a combination of digoxin. I have not described digoxin for any other scenario with respect to heart failure. You see, I've described much more superior drugs that we have now in the congestive heart failure topic. But in mitral stenosis, because it's a chronic onset disorder, yes, we definitely can be using digoxin. We can be using spironolactone, which is a potassium sparing diuretic, but it will help you manage the ankle edema component and obviously the pulmonary edema component as well in the patient. If there is a pulmonary artery hypertension, that also has to be managed on a war footing. Ideally, pulmonary artery hypertension development should not occur. I mean, if you identify the case early, there is no reason why he should go into pulmonary artery hypertension. We obviously have multiple drugs for management of pulmonary artery hypertension that can ease off the pressure, but then the prognosis will relatively be bad. In pulmonary artery hypertension, initially we start treatment with calcium channel blockers. But if they ask you to select one drug, which is the drug of choice for pulmonary artery hypertension, it would be ambrisentan. In fact, two findings for pulmonary artery hypertension that I've described in this particular topic is one loud P2 and one is a radiological finding that instead of the concavity at the pulmonary bay, there will be a very significant fullness and convexity present, by which obviously pulmonary artery hypertension can be identified. And I've already highlighted that if somebody is already having exercise intolerance, if it deteriorates very fast now, that indicates again a progressive deterioration and the pulmonary artery pressure is rising. Normal pulmonary artery pressure is going to be in the range of 15 millimeters of mercury. That's the mean pressure. But once it goes up to 30, in fact, that's the definition they can ask you. I mean, if the pressure goes up to double of normal, the mean pulmonary artery pressure, that definitely indicates pulmonary artery hypertension, and that heralds a bad prognosis for the patient. As they say, prevention is better than cure. So if you aggressively manage the patient, you definitely can prevent this bad prognosis from occurring. Because once that happens, I mean, the prognosis of the patient will dramatically, and the morbidity, mortality component will dramatically increase. We shall now be comparing the murmur of mitral stenosis with that of severe aortic regurgitation, where a substantially large volume of blood is going to come back in the heart of the patient. I would like you to compare the first diagram with the second one that I make before you. The first one is not having any lesion per se, it is just representing systole. So in this diagram, I have shown aortic valve to be open, pulmonic valve to be open, symbolizing ejection click. 80 ml blood is gonna race into the aorta and in the pulmonary artery without any problem. The problem is occurring in the phase of diastole. So you can see that in aortic regurgitation, there is going to be a diastolic murmur once again developing in the patient, like I was teaching you diastolic murmur for mitral stenosis. But this time you can see the reason why the murmur is coming up is because of the blood racing back into the lumen of the left ventricle. If you compare the two sides, pulmonic valve is closing rock solid, no problems. But the aortic valve leaflets are not able to coapt properly, which is going to contribute to blood to race back into the left ventricle of the patient. As this blood will race back towards the left ventricle, there's definitely going to be turbulence created. In fact, guys, in this condition, the turbulence can be so much that some of the blood can actually go and hit the mitral valve leaflets from bottom. If you look at the red arrow, what I'm trying to show here is that the blood will actually physically go and hit the mitral valve leaflet. Please appreciate that the problem in this patient is not in the mitral valve. The problem in this patient is in the aortic valve per se. The problem is defective A2, but the turbulence magnitude is so much that even the mitral valve gets involved. The theory for this description would be like this. This is what I'm saying. In a patient of severe, mark my words there, severe aortic regurgitation, there could be regurgitant jet or jets of blood. The regurgitant jets of blood are going all the way and they are hitting the undersurface. They are gonna hit the undersurface of the mitral valve leaflets. This is definitely gonna increase the turbulence that would be created. What I have just diagrammatically highlighted before you was actually explained by a very senior physician, I would say about 200 years ago, with a very simple stethoscope. So I want to highlight regarding Austin Flint murmur. In fact, our examiners, because they love to ask regarding this classical information. So Austin Flint murmur is a murmur of severe aortic regurgitation. It's going to be a diastolic murmur. And the highlight is not only that there's going to be turbulence created when the blood is coming back into the lumen of the left ventricle, but even the blood is literally reaching up to the mitral valve leaflets. Therefore, I'm now going to time this murmur for you. So this is S1, S2, which is going to be period of systole, and between S2 and S1, which have deliberately exaggerated the diastole duration and the movement just to make the murmur more visible before you. And this diastolic murmur will start right from S2 and then it will peak in the middle of diastole. The murmur that I'm highlighting at the moment before you will also be called as mid-diastolic murmur. But this mid-diastolic murmur is different from the one that I was teaching you for a mitral stenosis case. So in color black, I'm going to sketch the murmur of mitral stenosis, which was beginning from opening snap. Please notice that the murmur of aortic regurgitation of the severe variety and mitral stenosis will not begin at the same time. In person who's having a problem of severe aortic regurgitation, the problem is with the aortic valve. So the murmur will start the moment the aortic valve will close. But in mitral stenosis, the murmur will start from opening snap, peak bang in the middle of diastole the same way, and then we'll also be having a small secondary spike, which has been explained to you earlier, that is a pre-systolic accentuation. So you can definitely differentiate between the two murmurs on the basis of the point of the origin primarily. The common thing between the two is that both will be having in the literature written MDM, mid-diastolic murmur. So I'm just trying to compile a list of diastolic murmurs before you, and at the moment the minimum information that I want you to understand from this slide, the main take-home message from this slide is in severe aortic regurgitation, which is also called as Austin Flint murmur, it's gonna be MDM. And in this condition, I mean, he's deliberately in the theory mentioned the word mitral valve getting involved as a documented before you. The turbulence magnitude is so much that even mitral valve gets involved, though the actual problem is in a person is in the aortic valve leaflets. Now, just to see whether you've understood me or not, I'm gonna represent and draw the diagram once again, but in a slightly lesser magnitude. So let's look at what's gonna happen in a patient of mild aortic regurgitation. Please be patient while I just sketch this before you. This time again, the problem is in the aortic valve leaflets, but the amount of blood coming back in the heart is lesser. In severe aortic regurgitation, as much as 50% of the blood can actually leak back in the heart. In mild aortic regurgitation, let us say only 5 ml, 10 ml, few percentage or relatively lesser magnitude of blood is coming back in the heart. So I have just highlighted this blood coming back in, and you can notice that because less blood will come in, therefore the turbulence will be for a shorter period. You see, last time more blood was coming in, so therefore the turbulence was for a longer duration. This time magnitude of severity is lesser. I mean, the problem is still very much the same. There is a defective coaptation of aortic valve leaflets, but the bottom line is, in this case, when I'm going to draw the murmur before you, the duration of murmur is going to be relatively much shorter. Why? Because the amount of blood is lesser. This is how I'm going to draw the murmur before you. The sound is going to come right at A2, and then the murmur will die down. The intensity of the murmur will be decremental in nature. In a triangular fashion, I've shown the intensity of murmur decreasing subsequently. This that I've shown before you is technically called as early diastolic murmur. The simple logic to be remembered is in Austin Flint, because the magnitude of blood or amount was more, so it was a relatively longer duration murmur, and the manifestations were more profound. This time, because the amount of blood is lesser, so obviously the manifestations will also be lesser, and the noise will die down relatively faster. Just to trouble you with English, classical English, they might actually use this term decrescendo murmur. You see, we have the term crescendo, decrescendo, but at the moment I'm just using the word decrescendo to highlight that the intensity of the murmur is decreasing with time. In fact, to explain this murmur, I can say like this. Imagine an ambulance coming close to you and then passing by you. As the ambulance will come closer, noise will be loud, and when the ambulance goes away from you, the intensity of the siren of the ambulance decreases. Or imagine a bird flying over your head and the bird is producing noise. As the bird will come close to you, the noise will be at the peak intensity, and as the bird will pass over your head away from you, then the intensity of noise will reduce. He is just using this classical term that you would have read, seagull murmur. That just highlights what I just said. Imagine a bird flying over your head, then flying away from you. So as it will fly away from you, the sound produced from the bird will reduce. Either of the three terminologies, decrescendo, seagull murmur, early diastolic murmur, represents a relatively mild nature of the lesion. Let's do this once more. On the contralateral side, let us imagine a patient is having mild variety of pulmonic regurgitation. In a scenario pulmonic regurgitation, the problem is now on the right hand side. So I've written the word defective P2 this time. There's a defective coaptation of the leaflets which causes the blood to leak back into the right ventricle of the patient. Again, this will produce a murmur which will be called as early diastolic murmur, but I've deliberately drawn it in green color to highlight that aortic and pulmonic valves don't close at the same time. No, first aortic valve closes, then pulmonic valve closes. I have already explained the time lag between the two would be approximately 30 milliseconds. Just to see whether you understood me or not, just imagine if a person is having concomitant mild AR and mild PR, then murmur of which one will occur first? Because first aortic valve will close, first mild AR murmur will occur, then mild PR murmur will be occurring. I've just drawn that in a different color to sensitize you to the fact that aortic and pulmonic valves don't close at the same time, obviously. But the point of mine is that because the configuration of the murmur is same, both of them are classified as early diastolic murmur. Therefore, let us now summarize. In fact, this is one of the important parts of our discussion. I'm going to summarize before you diastolic murmurs, and I'm going to use a couple of mnemonics also now so that you are more comfortable answering this in the exam subsequently. When it comes to topic of diastolic murmur, usually they love to ask you regarding early diastolic versus mid diastolic murmur. Though they can also incorporate a pediatric domain and ask you regarding a late diastolic murmur as well, but most of the MCQs in general medicine are mainly between early and mid. The mnemonic that I want you to remember for early diastolic murmur goes by the name of GAP, G-A-P, one classical name coming up here. Alphabet G would stand for Graham Steele murmur. Now the usual query is, sir, you explained Austin Flint. What is Graham Steele murmur? I want you to remember that Graham Steele murmur will be encountered in patients with severe variety of pulmonary artery hypertension. And because of this pulmonary artery hypertension, listen carefully, the high pressure in the pulmonary artery can actually result in pulmonic regurgitation of the mild variety. You see, the pressure is so high that some blood can leak across the pulmonic valve leaflets on the account of pressure gradient, and this can cause a mild variety of pulmonic regurgitation. And as I explained to you, mild PR, they would be early diastolic murmur. When it comes to alphabet A, it means aortic regurgitation of the mild variety. Alphabet P stands for pulmonic regurgitation of the mild variety. In fact, the first and the last entry is almost the same. The only thing is the classical name has come up here. So I want you to remember Graham-Steele murmur was, important from exam perspective and historically also important because of this name. It is seen in severe variety of pulmonary artery hypertension, which results in this problem for the patient. Now let us compare this with mid-diastolic murmur, which is an important part of the discussion, and there can be a slight controversy here also, so I'll try to resolve it before you. Well, the controversy is that when it comes to MCQ of per se general medicine versus pediatrics, the problem is that the classical murmur of rheumatic heart disease, when you study rheumatic heart disease, I have highlighted this murmur, which is very classical. It is called as Kericum's murmur. I'll draw the diagram of that also, but at the moment I want you to remember that in Harrison, Kericum's murmur is given as a mid-diastolic murmur. In Harrison, Kericum's murmur is described as mid-diastolic murmur, but if you go through the traditional pediatric books, then in the traditional pediatric books it is given as a Kericum's murmur. So how to resolve the controversy is what I want to tell you. See, in most of the previous year exams till now, they have only asked about early versus mid. If you have to compare between early versus mid, you will answer Kericum's murmur as a mid-diastolic murmur. I put a star mark mainly to sensitize you to the fact that because Harrison is the book that they're using, so therefore it is comparison of early versus mid. In contrast, the word is in contrast. If it's a hardcore pediatrics question, which obviously will be having three choices, then it will be early versus mid versus late. Then you have to answer a late diastolic murmur. But if late is not in the option, don't comment on that. Just follow Harrison then and answer it as a mid diastolic murmur. If it includes late, then it is okay. Let's complete the mnemonic here. The mnemonic here is CAM, C-A-M, CAM. C would stand for Kericum's, as I already explained to you. Then is Austin Flint murmur. This is going to be a murmur of severe aortic regurgitation. Alphabet M would stand for mitral stenosis. This was actually the first murmur in the list of lesions that I'm discussing before you. And then you can add a word to this. I'll draw a shunt for that also, flow murmur, in a few minutes from now. So you can just use a mnemonic at the moment that I've highlighted. That is gap versus CAM. And then again an additional term that comes up from pediatrics is flow murmur. I'll prove to you how flow murmur will result in a mid-diastolic murmur subsequently. Now focusing on Kericum's once again, guys, why does Kericum's murmur occur in rheumatic heart disease? So the reason for that is valvulitis. You see, because of the Ashcroft nodules damaging the valve leaflets, there is a defective coaptation of the leaflets. In fact, what I'm doing in this diagram is what I want you to be aware of is that because there's a swelling of the tip of the valves, so because of the valvulitis component, there can definitely be blood leaking across these leaflets from left ventricle to left atria. When I describe this, the query of most doctors is that, sir, blood is leaking from left ventricle to left atria, then it should be a systolic murmur. You are saying diastolic. Please appreciate that because of the valvulitis component in rheumatic fever and rheumatic heart disease, initially the blood will leak from LV to LA, but the same blood has to come back also, no? The same blood, whatever blood will leak from LV to LA and will contribute to damage to the wall of the left atria, that same blood has to come back also. That blood will come back when? During the phase of diastole, and then it would be a flow. So I basically want you to understand that Kericum's murmur is actually a flow murmur only. It's a flow murmur. In pediatric books it is written, it is seen in the later part of the diastole, though in internal medicine books it is written in the middle part of diastole. So some subject variation can definitely occur, and I hope that you will be more flexible and receptive to the discrepancy in data that I'm saying. And I would like to highlight once again, in most of the exams they ask you about early versus mid, answer is mid only, as we follow Harrison. If it's a hardcore pediatrics question where it's early, mid versus a late scenario, then obviously you will give flexibility to the examiner in a sense that okay, he wants to talk about the hardcore pediatric domain. But this is an important table, guys, and I want you to be very thorough with it. And if you get the mnemonic gap versus CAM right, then you will be much more comfortable. Now let me explain to you what I mean by the word flow murmur. Again, please be patient and follow my line diagram here. And whenever I draw a line diagram now, I personally would suggest you to draw with me so that this becomes a second nature for you. Because you see, in the exam you won't have the ability to actually draw anything and visualize anything. Everything is at the moment. In the exam, because of the pressure cooker situation, I've usually seen people, trying to rather work out logic in the exam. You see, in exam you operate on a conditioning mode, that your brain is already tuned to the data. Like for example, look at this. I am teaching you a patient who's having a atrial septal defect, which could be associated with Down syndrome, for example. So obviously the blood is going to leak from the left atria to the right atria because of a pressure difference of about 4 millimeters of mercury. And now I'm going to show the venous return also. Now, when you look at the venous return in the patient, I have here tried to highlight that the amount of blood that will be going in the right ventricle. This will be because of two reasons. One is obviously the venous return, but then I've just done a bit of green shading to say that significant contribution will also be of the shunt, no? In patients who are having atrial septal defect, which is going to be a congenital heart condition seen with Down syndrome, there's definitely going to be overloading of the right side of the heart. In fact, these patients can develop a right ventricular failure due to volume overloading. The message is that because there is more blood going across the tricuspid valve, listen to my words carefully, guys. I'm saying because there is more blood going across the tricuspid valves, it will cause more separation of the tricuspid valve leaflets, and more separation would mean more elastic recoil. And as a result of this, one, you can definitely anticipate changes in the heart sounds, but more importantly, because there is more flow of blood. And when does flow of blood occur into the ventricles? Diastole, right? The more turbulence which is occurring in this condition is because of the excess amount of blood which is coming across via the shunt. So in these patients, I'm using the word flow murmur. In fact, just to see whether you have understood me or not, that flow murmur is obviously a diastolic murmur. You can see from the diagram, I mean flow of blood. In left side, it will be relatively lesser. In fact, I'll just use a different color to highlight that the amount of blood coming in the left side will be lesser as compared to right hand side. That explains the splitting of second heart sound also, guys. But since splitting of second heart sounds is what we have already done here, I just want you to be sensitized to the fact when you have more flow of blood across the valve leaflet, there will be turbulence, and the more flow is occurring during the phase of diastole. If they simply ask you what is the shunt murmur in a case of AST, then your answer is shunt murmur is absent. Why shunt murmur is absent in ASD is because of the pressure difference. No, left to right atrial pressure difference is only 4 millimeters of mercury. That is too less to produce any kind of turbulence. What you will get in ASD will be mainly flow murmur. In fact, there can be two flow murmurs in ASD. One is going to be what I've just highlighted before you. That is a mid-diastolic murmur. Why I'm saying mid-diastolic is because maximum flow of blood in the ventricles occurs bang in the middle of diastole. So mid-diastolic murmur. The same blood will have to go into the pulmonary artery also, but the blood goes into the pulmonary artery during the phase of systole, no? So that will incorporate the word ejection systolic murmur. At the moment, I'm not focusing on that. I just wanted to highlight why did I use the word flow murmur per se. So flow murmur usually occurs in congenital heart conditions where there's going to be excessive flow across any valve leaflet. And therefore, you can once again go back to this slide and remember the mnemonic that I explained to you. That is gap versus cam. And the questions that are going to be asked on this topic are going to be of the all except variety. At this juncture, I also want you to be sensitized to the fact that if they ask you what is the most common murmur in children, then do not answer this as the murmur of VSD. I agree that VSD is the most common congenital heart disease in children, and you studied that very well in pediatrics. The overall commonest murmur in children would be answered as innocent murmur. Well, children are innocent. But here, why we are saying it innocent murmur is primarily that innocent murmur is due to hyperdynamic circulation occurring in children. It's always a systolic murmur. Let me explain what I mean by the word hyperdynamic circulation. Imagine a child having fever. In fever, whenever body temperature rises, heart rate also increases. That increase in the heart rate can cause turbulence during the phase of ejection into the aorta. So there can be a systolic murmur developing in a patient. I repeat the fact once again. Heart is beating faster. It is ejecting blood with a lot of, I would say, turbulence into the aorta. So you could hear a murmur in especially a thin child, right? And this will always be a systolic murmur. The moment the fever will go away after giving crocin or paracetamol, the murmur will disappear. So we're calling it innocent because it is not highlighting any valvular or congenital heart disease. It is just highlighting a fast circulation. Let me give another example. There's a child with severe anemia. He does not having any cardiovascular lesion. It is just a kid with anemia, and because of the anemia component, there is a possibility that the heart will be beating faster. Why? Because in patients of anemia, they can go into heart failure. So to prevent that from happening, the sympathomimetic drive in the body will occur. You see, heart failure can cause pulmonary edema. Now, how to clear pulmonary edema? Work more. So in anemia patients or severe anemia patients, there is always a tachycardia. The tachycardia is because the heart is beating faster to clear off the fluid and prevent a severe decompensated pulmonary edema developing in a patient. The point is, when the heart will beat faster, it will obviously contribute to turbulence, and therefore murmur can be heard in anemic children also, though there is no heart disease. When you treat this iron deficiency anemia, which is the commonest form of anemia in children, you will notice that after a couple of months, as the hemoglobin values will rise, the murmur will also disappear. So that is what I meant by the word innocent murmur. Now I will incorporate one more lesion before you, and this one would be called as coarctation of aorta. In fact, when I talk about coarctation of aorta, you would be reminded of the fact that we study about this topic usually even in pediatrics with respect to Turner syndrome. At this junction, I also want to tell you that if they just write which is the commonest valvular lesion or which is the congenital heart disease, or he just says what is the heart disease seen with Turner syndrome, then the first answer is not coarctation of aorta. Remember, I said coarctation of aorta is associated. I did not say commonly seen with Turner syndrome. The commonest valvular lesion with Turner syndrome should be remembered as bicuspid aortic valve. I'll just jot down the data before you. In Turner syndrome, that is 45XO, bicuspid aortic valve is relatively more common as compared to the lesion that we're discussing, though coarctation of aorta is obviously important. So let me now draw the line diagram of coarctation of aorta and the collaterals that would be seen in this. You see, the problem in this patient will be again for the left ventricle, which will have to work against a substantial amount of resistance, because you can see there is a narrowing, especially at the level of the descending aorta. These are the two subclavian arteries. So if they ask you what is the usual site for coarctation of aorta, your technical answer will be it is distal. And I think the anatomist has also spoken about coarctation of aorta. This is going to be usually distal to the origin of the left subclavian artery. And because of this narrowing component, I think that you can understand there's an outlet obstruction, so there can be ejection systolic murmur. Every time the left ventricle has to work against a resistance, no, there will be some turbulence produced against which the left ventricle has to work. You see, these patients will obviously have a left ventricular hypertrophy because the left ventricle is having to work against a resistance. So the left ventricle is generating more force and the orifice is also narrow. So the combination of the two, more muscle and obstruction present, will contribute to turbulence. So if he says what is the murmur seen in patients of coarctation of aorta, your first answer is obviously ejection systolic murmur. But now a problem will develop, because after all, less blood is going to legs. Lots of these patients might actually develop differential cyanosis. The toes of these patients will be blue, whereas the fingertips of these patients is pink. I've highlighted these patients will be having a differential cyanosis. That's because of less blood going down to the lower extremity. So the body will obviously fight back, and the fight back I mean is there can be collateral formation in this patient. The blue that I'm representing is the collaterals. From the proximal area, that is proximal to the obstruction, to the distal area, there is development of collaterals as these patients will grow. The collaterals are going to be transporting high pressure blood. It is aorta blood going across these collaterals from the proximal segment to the distal segment. So the turbulence will obviously be there. Why? Because blood is now traveling through these very narrow blood vessels. These very narrow blood vessels would be referred to as collaterals, and therefore the question will be what is the murmur that is heard. I already told you ejection systolic murmur is heard in these patients initially, but as the collaterals will develop, the murmur will rather increase in duration. Now listen to this very carefully, guys. This is first, second heart sound and a first heart sound again. In these patients, when will this blood flow across the collaterals? Will it be during systole or whether it will be during diastole? The blood will flow from the proximal segment to the distal segment, not only in the phase of systole. Obviously it will flow in the phase of systole because pressure is high, but even in diastole due to aortic recoil, guys, the flow of blood in this condition will occur both in the phase of systole and diastole. So the murmur that is going to occur in this condition will be one having a substantial amount of intensity. And look at the surprising thing that I've drawn before you. This would be called as a continuous murmur. A lot of guys casually answer pansystolic murmur. No guys, I'm not talking about a pansystolic murmur. Even its turn will come. I'll describe when you hear a pansystolic murmur. At the moment, I want you to hear a murmur or understand a murmur which is gonna be rather having a peak at S2. Such a murmur which is having two features. Point number one, murmur heard both in systole diastole. Second, it peaks at S2. This is definition of what we call as continuous murmur. So remember, from the alphabet C, coarctation of aorta, there will be a continuous murmur heard in these patients because of the collaterals. There are two aspects that I said. The original murmur in the patient is ejection systolic because it is an outlet obstruction. Mitral stenosis is an inlet obstruction. Aortic stenosis and coarctation of aorta are outlet obstruction. Because of the outlet obstruction, whenever heart will contract, it is working against resistance, so there is turbulence. The turbulence causes ejection systolic. But when I talk about collaterals per se, that is why I changed the ink. As the child will grow, as the patient will grow, there would be a continuous murmur that would be heard in these patients. And in fact, it is mainly for continuous murmur that I wanted you to study about it, because ejection systolic murmur is relatively easy to understand. Ejection is occurring against resistance, so it will produce a murmur. Let us therefore make a list of where are or what are the conditions where continuous murmur can be heard over and above what we have just discussed. From pediatrics, I think everybody is clear. Patent ductus arteriosus will also be having a continuous murmur, even called as a machinery murmur. Why? Because the aorta is connected to pulmonary artery, and pressure of aorta is always more than that of the pulmonary artery. In coarctation of aorta, it is the proximal segment pressure which is higher than the distal segment. The third one you can take a little easy at the moment, mammary souffle. Well guys, the reason for mammary souffle will be increased blood flow via the internal mammary artery on account of pregnancy. So the third finding that I'm saying is incidental finding of pregnancy. There's nothing pathological about it. It is just a auscultatory finding related to pregnancy. When you're auscultating a female patient during her pregnancy, cardiovascular auscultation you will hear a whooshing sound in the chest. That's because of more blood flow. There's nothing pathological about it, but still it has been discussed in exam or at this junction is because the character of sound, you see the flow of blood continuously occurring across this artery is what is responsible for or is gonna mimic a continuous murmur. The next condition is venous hum. Again, if you look at it, venous hum is basically a sound produced due to dilated veins in the chest. Because of the turbulence of blood in the dilated veins, I am talking about bigger veins at the moment, like superior vena cava. So therefore, venous hum will also be occurring both in systole and diastole. The next condition is rare, but is still asked. This could be occurring with respect to connective tissue disorders like Marfan syndrome, rupture of sinus of Valsalva. Well, what is the importance of rupture of sinus of Valsalva is that now the aorta will be communicating with the right atrium. Imagine aorta is a high pressure, ultra high pressure circulation. Atria is a low pressure circulation. You have a communication. Obviously, the patient is going to die, but that flow of blood from a high to low pressure circuit will result in a continuous murmur developing. The next condition is again very important because a lot of guys casually read this as pulmonic stenosis. You see, if I say plain pulmonic stenosis, just like aortic stenosis, plain pulmonic stenosis will cause a ejection systolic murmur. But look at the words that I've said here. I said peripheral pulmonic stenosis, which means the narrowing is in the pulmonary artery and its branches, and see blood flows towards the lungs both in systole and diastole. In you and me, blood is flowing into our lungs both in systole as well as diastole. If there's a narrowing of the pulmonary blood vessels, then there would be turbulence created. So peripheral, the word is peripheral pulmonic stenosis. If I remove the word peripheral, if I just say valvular pulmonic stenosis, subvalvular or subpulmonic stenosis, supravalvular pulmonic stenosis, for all pulmonic stenosis, subvalvular, supravalvular, it is ejection systolic. But if it includes the word peripheral, it means it's a pulmonary artery narrowing. Blood flows in the lungs all the time, systole plus diastole, so it's gonna be a continuous murmur. Just to see whether you've understood me or not, I'll just draw a line diagram here before you, and then we'll come back to this slide once again. Imagine you have a person of rheumatic heart disease with both MS with MR. Now, when it comes to mitral regurgitation, because the blood will leak from the left ventricle to left atria all through the phase of systole, you will have a murmur that will be having a uniform intensity all through the phase of systole. So this that I've drawn before you is the murmur of mitral regurgitation. We call it a pan-systolic murmur. It is called as pansystolic because the intensity remains almost constant all through the phase of systole because blood is leaking from left ventricle to left atria. Since my patient is also having mitral stenosis, in mitral stenosis, I've already sensitized you to the fact that there will be a loud opening snap, and after that the murmur will begin like this. It will peak in the middle of diastole, then will have a small secondary spike as well. You will notice that even the murmur of MS with MR is also having systolic plus diastolic configuration. But is it looking like a continuous murmur? No, because continuous murmur should be peaking bang in the middle. Like continuous murmur should peak bang in the middle, but you can notice the current shape that are drawn before you does not look like that of a continuous murmur. So MS with MR cannot be called as, or cannot be by definition or included in the list of continuous murmurs. Let me make you practice this once again. I have a person who's having a concomitant aortic stenosis with aortic regurgitation. Now, if a person is having valvular aortic stenosis, then this is what's going to happen. Aortic stenosis will result in a murmur whose intensity will first rise and then decrease. The technical term for this one is ejection systolic murmur. You see the difference between pan-systolic and ejection systolic is in pan-systolic the intensity remains almost the same, and in ejection systolic the intensity will first rise and then fall, and therefore ejection systolic is also called as crescendo. Decrescendo murmur. Remember, I was teaching you decrescendo murmur for aortic regurgitation, but now I'm teaching you a crescendo decrescendo murmur, which is very classical for valvular aortic stenosis. And let me say the patient is also having a severe variety of aortic regurgitation concomitant with this. Therefore, this murmur will be a mid-diastolic one also. You can see once again I have drawn a diagram in which there is a systolic as well as a diastolic component, but is it looking like the murmur or continuous murmur? No, because one of the important characteristics of continuous murmur was peak at the level of S2. I'll just go back at the shape once again. This is what I drew, a big triangular configuration with peak at S2. And compare this with the two murmurs that are drawn at the moment. I want you to understand that none of the combination valvular lesions, whether they give TS with PR, TS with TR, MS with MR, AS with AR, none of the combo lesions will ever satisfy the definition of a continuous murmur. And in fact, this is again an important aspect that I want you to remember. In fact, the main reason why we're discussing this topic is that they'll ask you to compare or say conditions where diastolic murmur is heard, continuous murmur is heard, or systolic murmur is heard. So if you try to remember what I said 6 points initially, you see the main focus is if you get cam versus gap right, 6 points and 6 points at the movement. So the total data that I told you is 12 points. If you get these 12 points imprinted in your brain, I'm very sure that you will be more comfortable with the topic of murmurs. I shall now be summarizing the systolic murmurs before you. There are three configurations that I have explained. First of them would be having a triangular configuration where the intensity will first rise and then will come down. So we are going to call it a ejection systolic murmur or ESM. In the second one, you will notice that the intensity will not change much. It would remain almost the same all through the duration of systole. So we will call it a pan-systolic murmur. And then I'll talk about what we call as a late systolic murmur as well. In fact, in this late systolic murmur, I want you to notice that in between patient will be first having mid-systolic clicks. These vertical black arrows are not to be mixed with ejection click, which is perfectly normal. It is mid-systolic clicks, and these mid-systolic clicks would be followed by a late systolic murmur developing in the patient. So let's have a look at how to remember all this. The mnemonic which can be used to remember ejection systolic murmurs is by the name of PAS. In fact, if you just look at the mnemonic, PAS would mean pulmonic and aortic stenosis will cause systolic murmurs. So I can incorporate the word pulmonic stenosis here. I can incorporate the word aortic stenosis here. Please remember the fact per se, when I say the word pulmonic stenosis, pulmonic stenosis is usually encountered in congenital heart disease. When would an adult person be having a pulmonic stenosis? So one would be a valvular lesion by the name of carcinoid syndrome. In fact, in carcinoid syndrome, I have mentioned it, but I'm going to highlight this fact once again that carcinoid syndrome can contribute to valvular lesions also. The mnemonic for that is TIPS. TIPS would mean tricuspid insufficiency and pulmonic stenosis. On a prevalence basis, tricuspid insufficiency is relatively more common as compared to pulmonic stenosis, and that same pulmonic stenosis component has come up here. Another scenario where you read about pulmonic stenosis and can be an adult patient is Noonan syndrome. Noonan is a variant of Turner syndrome. You see, Turner syndrome and Noonan syndrome patients would look the same. The only thing is the difference in the two will be in the genotype. I mean, Turner is 45XO, this could be like 46XX or 46XY, but physical appearance can be same. Aortic stenosis can occur primarily because of bicuspid aortic valve in pediatric age group or because of calcification. And because I was saying the word aortic stenosis, I can also add a subvalvular aortic stenosis. This subvalvular aortic stenosis would be called as hypertrophic obstructive cardiomyopathy and is discussed in the cardiomyopathy section. In contrast, when it comes to pansystolic murmur, the two standard answers for this would be ventricular septal defect, because the blood is leaking from left ventricle to right ventricle all through the duration of systole, and in mitral regurgitation the blood is leaking from left ventricle to left atria. You see, if you look at the shunt of VSD, the only thing is blood is going left to right ventricle, whereas when it comes to mitral regurgitation it is going from left ventricle to left atria. So direction of shunt is different, but otherwise the blood is always going from high pressure circuit to low pressure circuit. So because this is happening between two chambers of the heart with variable pressures, I'm using the word pansystolic. VSD and MR always go together, guys. Even when you follow heart sounds, no, VSD and MR both were having wide variable split second heart sound. So in fact MR and VSD usually they tend to be mentioned together whenever they are given in the question. So that's one small hack that can definitely help you. And when it comes to this classical terminology, which I'm sure you were able to pick up, mid systolic clicks and then a late systolic murmur, this is gonna be a feature of mitral valve prolapse. Now that is obviously on the examiner, that he does not want to write the word mitral valve prolapse. He wants to write like floppy valve syndrome, or he wants to write the word Barlow syndrome. I mean, they love to ask about syndromes per se. So wherever possible, I mean, I try to incorporate one. And even in pediatrics also, there's a huge list of syndromes that you actually need to remember. So I'm being selective about what you need to understand. The reason why in mitral valve prolapse there's gonna be this late systolic murmur is because, let us say this is mitral valve leaflets. Below this are chordate tendineae. These chordate tendineae are powered by papillary muscles, which I'm currently shading at the movement. The bottom line is, guys, that if there is a papillary muscle dysfunction, like let me say I'm gonna show that this papillary muscle is damaged by ischemia, like the ischemia that occurs in myocardial infarction. So you can see that on one side the structural support is gone, the other side chordate tendineae will be working much more than normal. So what I'm saying is the multiple chordate tendineae supporting the valve leaflets from within, if couple of them snap with respect to the damage to the papillary muscle, then the remaining chordate tendineae will have to take more strain. That is, when the blood is gonna hit the undersurface of the valves will bulge up. That's normal physiology, that valves do bulge up. But in this case, because the structural integrity, the structural support is lesser, the valve will bulge up higher than normal, and because of the stretching of the remaining chordate tendineae like a rubber band. Imagine there are 8 chordate tendineae. 2 of them are not working because of the connections getting snapped or the hypoxic damage. So the remaining chordate tendineae will undergo more stretching. The valve will also bulge up higher than normal. So due to more stretching, the turbulence created is called as mid-systolic click. And there's itself a lecture on this in the earlier part of the discussion. Even in the heart sounds topic, I've talked about mitral valve prolapse per se, and mitral valve prolapse and MR are also discussed separately as well. In fact, mitral valve prolapse, why it occurs, I have highlighted the leading reason for mitral valve prolapse is myxomatous degeneration of the valve. That you can anyway go through from the section of MVP and mitral regurgitation as well, but this is again one table that I want you to remember, guys. At this junction I want you to remember diastolic murmurs versus continuous murmurs versus systolic murmurs, and if you can just hand draw these small tables by yourself, you would be on your way to getting these questions and your strike rates relatively better. Towards the end of this discussion, I would like to mention a very specific statement. You see, I am asking my patient to stand, or I'm asking him to perform a Valsalva maneuver or going in for amyl nitrate inhalation. Now listen to my words very carefully. I said when you make the person do the following maneuvers: Valsalva, standing, amyl nitrate inhalation, the common thing about all the three is that they will reduce the venous return to the heart. If you reduce the blood going into the heart, the turbulence produced due to murmurs will also be lesser. Therefore, in all three of these, when you make a patient do any of these maneuvers or all of these maneuvers, all murmurs decrease with Valsalva, standing, amyl nitrate inhalation. Logic is less blood is going to the heart, so less turbulence, except there are 2 of them. Hypertrophic obstructive cardiomyopathy and mitral valve prolapse always behave opposite of what other murmurs will behave. So most of the time they will ask you this except scenario. As I was saying, all murmurs will decrease in intensity all murmurs will become relatively softer because less blood is going towards the heart, lesser turbulence, except hypertrophic obstructive cardiomyopathy that will become louder, and mitral valve prolapse that will become longer. Now mark my words there guys, I said two things, louder and longer. They can even trouble you with these English words as well, no? Because one is duration, one is intensity. The message I want you to remember is all murmurs decrease with Valsalva standing amyl nitrate, less blood going to the heart except these two. Let's practice this once again and then I'll introduce a line diagram here as well. I am requesting my patient to do squatting, or I can ask my patient for a hand grip. Lots of time, person is sick, he may not be able to squat or do sit-ups. So I will just make the patient shake hands with me and ask him to squeeze my hand, that is hand grip. So I want you to remember that when you make a person squat or do hand grip, then what happens is that the peripheral resistance also increases and venous return to the heart also increases. I'm saying all murmurs will increase with respect to you either doing a hand grip in the patient, or if he's fit enough you can definitely make him squat, because the advantage of squat will be now two things will happen. One will be that there will be more blood rushing towards the heart because of squeezing of the leg muscles while he's squatting, and second, the peripheral resistance and the afterload will also increase. If the peripheral resistance or the afterload increases, heart is working with more gradient means the murmur intensity will increase. All murmurs increase with, that's the intensity that we're talking about, right? So please be clear, I'm not talking about duration anymore, I'm talking about intensity guys. All murmurs increase with intensity with hand grip and squatting, except, again the exception is still the same. The exception is hypertrophic obstructive cardiomyopathy and mitral valve prolapse. Hypertrophic obstructive cardiomyopathy in this particular case, mark my words very carefully, will become softer and mitral valve prolapse will become shorter. So again they can trouble you with English, no, louder versus longer and softer versus shorter. So I would like you to practice this very characteristically. And when it comes to hypertrophic obstructive cardiomyopathy guys, this is very extensively asked in the exam, this particular statement that HOCM murmur will always behave opposite of normal. Why that is so, I've discussed in cardiomyopathy and I'm highlighting this once again. Now let us see why hypertrophic obstructive cardiomyopathy will behave opposite of what is normal. You see in these patients, one, there is always an echocardiographic finding that I've highlighted called as SAM, systolic movement of the anterior movement of the mitral valve. So this that I'm highlighting in red is the mitral valve leaflet, and the one that I'm highlighting in white is the septal hypertrophy. So you can very well notice that blood will actually have to go across this narrow tunnel which is due to the mitral valve displacement as well as the septal hypertrophy, and this is technically called as left ventricular outflow tract obstruction. It is written as LVOTO. The problem in patients of hypertrophic obstructive cardiomyopathy is that the aortic valve leaflet is fine. You can see no problem in the aortic valve, but below the aortic valve there's a tunnel present here. That tunnel is limiting the amount of blood going in the heart. Now for this tunnel, I want to highlight that the space which is present in this tunnel is dependent on the volume of blood in the ventricular cavity. If more blood is present in the ventricular cavity, then this tunnel will become wider and the turbulence will become lesser. On the other hand, let me say if there is going to be lesser blood in the left ventricular cavity, then this tunnel will become narrower, and if the tunnel is narrower, there will be more turbulence that is created. Let's take up a scenario wherein HOCM, I'm asking the person to stand. In a person who is not having HOCM, if a person will stand, venous return to the heart will be lesser. So if there's any valvular lesion, less blood would mean that there is going to be decrease in the turbulence. But in HOCM, what is happening is the movement, less blood will be coming in the left ventricle. This tunnel will become also relatively narrower. You see, I said the diameter of this tunnel or the space present in this tunnel is directly related to the volume of blood. If the volume of blood in the left ventricle will reduce, why I said less blood is I'm making the person stand. If less blood will come in the left ventricular cavity, this tunnel will be narrower, and if the tunnel is narrower, the turbulence will be relatively more. And even if you don't get into this diagram of SAM versus LVOT guys, if you just remember this information that I highlighted at the moment, you would definitely be able to solve the question in a sense that HOCM murmur will always behave opposite, so would be the mitral valve prolapse murmur. These are the details that I want you to understand for this topic, and I thank you for your patience for hearing me out here, and I'm very sure that the more you will learn these facts, more better your performance will become. As I usually say, I'll repeat the facts once again guys, keep hammering, keep focusing, keep on doing questions on regular basis, and you'll do great wonders. You'll come out with flying colors. Thank you so much.